This computer. All right.
Oh,
All
hey,
right.
Taylor. Hey, seeing lots of my peeps here.
Right. Feeling good.
Yep.
Okay. All right, let's do this. Hi, folks. It's me hosting today because Rebecca's away, or not away, but in another important meeting. So you're stuck with me for this little bit. Welcome to the first of 3 of our research spotlight webinars for the summer session. So this time around, it's substance use patterns and safer supply preferences among people who use drugs in British Columbia. We have Dr. Jane Buxton. We have Jessica Xavier. Sorry, I didn't even ask you about the pronunciation. I apologize. Or Xavier, Phoenix Beck McGreevy, and Jenny McDougall. I'm going to let you folks introduce yourselves when we get there. There are a couple little housekeeping pieces I want to get to first. The first, I'm going to leave this slide here. I actually want to talk to you about where I'm coming from today and what I'm feeling anxious about today in regards to the climate. So myself, I'm actually an uninvited settler. I'm currently occupying Jojagi, or so-called Montreal. So the Ganagahagi Nation are recognized as the custodians of the land, but it's also noted as a meeting place for many different Indigenous nations in the region. Today I'm feeling particularly anxious because we have a tornado warning and we have a big storm warning, and it's all kind of caused by climate change. And today I really wanted to remind folks of the linkage between climate justice and Indigenous rights and human rights, and really remind us that we really have to take care of this land and territory and really respect it and honor it, because this is really scary stuff, and so I really encourage folks to take active steps to working towards minimizing their personal impact, but also taking bigger pushing bigger changes, like policy changes that particularly put Indigenous rights and Indigenous climate justice at the forefront of our conversations. I invite you, as folks that are joining, to pop in where you're coming from in the chat, which I'm not even reading. Who knows what y'all are saying there. We'll move on. I will tell you a little bit about the community of practice. We are funded through Health Canada's substance use program. I am responsible to tell you that the production of this webinar has been made possible through that financement. However, the views herein expressed do not necessarily represent the views of Health Canada. I will let Robin, my colleague, pop in the link to our website so you can join us if you haven't already. We are recording. I've remembered to do this. We will post it on the website. We'll also have a nice little resource page with everything in one place. So we will have the recording, we'll have the slide deck, which the team here has been super lovely in sharing with us. We'll also have a number of other things like their report, their infographics, etc. If you're having technical difficulties, the best thing to do, log out and rejoin. Just keep trying that. Otherwise, you can chat to us if you're really having issues. The other thing we do have is closed captioning, so that's enabled. Unfortunately, it's just in English right now, but you can enable that at the on the little tab bar of your Zoom. You should have an option under More to activate captions. Otherwise, we have a couple of events coming up that I want you to know about. This one is happening next week, actually. Or no, sorry, the week after, actually. It's on a Monday, on the 24th. That's our next research spotlight. That's with Dr. Carol Strike, Dr. Adrienne Gouda, and Rose Schmidt. Hi, Rose, if you're on the call. I don't know if you are, but hi. It's about prescription for safety. It's a study on safer opioid supply programs based in Ontario from Toronto and London. So that's going to be a report launch. So please register for that. There's also another research spotlight happening in August, on August 21st. It's also a Monday, about women experiences in injectable opioid agonist treatment programs in Vancouver. Again, Robin is probably dropping links as I'm going through this. And again, join us if you haven't already, learn more. We have a bunch of resources there at your disposal. I'll stop sharing now, and I'm going to magically disappear I'm going to close my webcam, but we're still going to be managing the chat. If you have any questions, please pop them in the Q&A box that's in the Zoom tab. That'll make sure that no questions get missed that are popped in the chat. Otherwise, please feel free to use the chat because that can be a fun place to connect with folks as well. Everybody should be able to talk to everybody. Let me know if you can't. Yeah, otherwise, I think I'll turn it over to Jane. Jane is a professor emeritus at the University of British Columbia and works with the Patterns and Preferences Study as the principal investigator. And this is with the BC Centre for Disease Control. So I'll turn it over to you and I'll let you take it from there.
Great. Thanks very much, Alex and Robin, for adding all those links as we went along. And hello, everyone. I'm Jane Buxton, and I have the pleasure of being the principal investigator on the Perspectives on Safer Supply project. And I just wanted to give a shout out to everybody on the call, really just thanking everyone for all that they do, working so hard to save the lives of their peers and their loved ones. I was really pleased to hear Minister Bennett recently publicly state that safer supply programs are showing encouraging evidence of saving lives. And in BC, we're very fortunate to have our Provincial Health Officer, Dr. Bonnie Henry, and our Chief Coroner, Dr. Lisa Lapointe, who are openly supportive of safer supply. But as we all know, every day we hear the resistance and the misinformation that comes to us from many directions. So our plan today is to share the experiences and the voices of people who use substances in BC and the recommendations that emerged from this project that we've been engaged in. I'm delighted to present with Phoenix Beck-McCreevy, who was a research associate on the project, Jenny McDougall, a research assistant, and Jessica Xavier, who was the research coordinator. And all have been really engaged, not just in performing interviews, but analysing the data and then coming up with, what quotes we should be including in the report. But first, I'll hand it over to Phoenix, who will provide the land acknowledgement.
Good morning, good afternoon. First and foremost, we respectfully acknowledge that this work was conducted across the occupied, unceded, ancestral, and traditional territories of more than 200 First Nations across what is known as British Columbia colonially, and that the BC Centre for Disease Control is situated on the territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. We are, pardon me, we are also grateful. One second. We are also grateful to the peer research associates and assistants, many of whom are members of the Professionals for Ethical Engagement of Peers, who assisted in developing the survey and question guide, facilitated interviews and focus groups, and assisted in the interpretation of findings. We also want to thank the participants, particularly for sharing their knowledge and insights. And as we all know, this work is all happening amongst the backdrop of the thousands of devastating and preventable deaths that have occurred in British Columbia and across the country due to the illicit drug supply, the toxic illicit drug supply. And we want to acknowledge and take a moment to think of the people who continue to suffer from the losses of their loved ones and who continue to suffer under unethical drug policy. I'm sorry, my cat is extremely attention-seeking this morning. Thank you very much. I am going to pass it back to Jane.
Thanks, Phoenix. So as mentioned, today's presentation the four of us are giving is on behalf of a much larger team of co-investigators. And as Phoenix mentioned, many people who have lived and living experience of substance use. And the input and participation were a priority to ensure that our findings and recommendations were relevant, acceptable, and feasible. The authors have no conflict of interest, and as always, we have to say that the interpretation is that of the co-authors, not of the funders. So the report is actually based on two main data sources. One is a quantitative data source, which is from the BC Harm Reduction Client Survey. And that has been funded by Health Canada through the Substance Use and Addictions Programme. It's administered to people aged 19 and over who are attending harm reduction sites right across BC. So it's not just in the Lower Mainland, it's right across the province. The second source is through qualitative data, and these were interviews and focus groups which were led by peer research assistants and the research coordinator and research associates under the Understanding Substance Use Patterns, Preferences and Needs, Informing Safer Supply and Safer Use Services. And this was funded by the BC Ministry of Health under their Community Crisis Innovation Fund. These participants were aged over 16 and over and had used opioids or stimulants at least once in the month prior to the interview or the focus group. So this is really an outline of what we're going to be talking about, and it's going to be a tag team, so we'll take it in turns. I'll provide the background, really why, justification for why the study was necessary, and Jessica will describe how we did it, the methods, and then the four of us will describe what we found. And if you look under the findings, we will concentrate on the opioids, stimulants, benzodiazepines, and prescribed safer supply. I will give the numbers from the survey, and then we'll hear from Jenny and Phoenix, who will share the voices of people who use substances and the recommendations that emerged. Just a little sidebar, the recommendations, when you come to them, it's really a test to see if you're still awake. The numbers will not be consecutive. They're the numbers that are in the report. So we can actually count, just so you know. And then we'll have a discussion around the policy and practice implications. I don't need to tell this audience about the horrific and unacceptable preventable loss of life that's occurring due to the unregulated and toxic drug supply that we have at the moment. The number of deaths in BC has steadily increased, with the exception of 2019, since 2012, with more than 2,000 deaths per year in both 2021 and 2022. And sadly, so far, for the first 5 months in 2021, there have been over 1,000 deaths, which will give currently is giving a rate higher than the past 2 years. From the figure on the right, you can see the number of average number of deaths per day. In the last 2 years, 2021 and 22, it is over 6 deaths. I'm really just to point out, to compare this with the period 2000 to 2010, there was less than 1 death per day. So it's a huge increase and totally unacceptable. I think we all know the reason that the deaths are occurring is the unregulated toxic drug supply. This is a figure that's taken from the coroner's report, and it illustrates the drug types that are relevant to death. So not just that they're detected, but they are relevant to the decedent. Fentanyl, as you can see here, is implicated in over 85% of deaths. So fentanyl really is the main reason that people are dying. But I think you can also see that methamphetamine, that's that slightly paler blue, has increased over time, and it's at 43%. Cocaine has decreased a little bit, and benzos, as everybody knows, have come into the mix, and that's at 29%. So I'm now going to hand over to Jessica, who is going to provide some context around safer supply.
Thanks, Jane. So I think this group, I'm going to assume, is fairly familiar with safer supply and the background, but just to ground some of our findings in the aims of safer supply and the context here in BC. So as we know, and as Jane mentioned, the crisis is ongoing, and the illegal drug market is becoming more and more toxic. And this is despite increasing interventions and efforts to reduce overdose. So things like accessible naloxone, supervised consumption sites. And of course, there's evidence that these things are reducing overdose, but clearly it's the magnitude of the crisis proves that it's not enough. And so the term safer supply comes from this idea that there is a possibility of providing a supply of drugs of known content by regulating the production and distribution, and this being a way of actually preventing overdoses in the first place, rather than focusing on only responding to overdose. So we spent quite a few meetings and time with our peer advisory, really defining a safer supply and how we wanted to define it for the sake of this project. I think, there's variations in what's included and not. And so we ultimately landed on using the definition by PWUD in their 2019 report, which states that safer supply refers to a legal and regulated supply of drugs with mind-body altering properties that have been accessible only through the illegal drug market. So the key here that came out of some of these meetings and with our peer advisory being that piece around mind-body altering properties, and the substance is actually providing a true alternative for people. At the time of the study, which was with the quantitative and qualitative, sort of between 2019 and 2021, safer supply in the province mainly referred to substances provided under RMG, risk mitigation guidance. And so what that meant was at the time of the study, most who were prescribed opioids were prescribed Dilaudid or MS-Lon. There were only a couple of programs offering fentanyl and diacetylmorphine across the province. In terms of prescribed stimulants, that would have been Dexedrine and Ritalin, with no programs offering methamphetamines or cocaine. And then most were in oral formulations with very few offering injectable options and then offering inhalable options. And that's pretty representative of the context today. And just to add that our participants were not necessarily all folks who were accessing safe supply. So we were able to get the perspectives of people who were on safe supply, what their experiences were, but also people who were experiencing barriers and who were not on safe supply. And I'll pass it on to Phoenix.
So as you can see on the infographic above, we chose a number of different data sources, evidence sources, which was informed by administrative data, such as coroner's, ambulance, and drug toxicology data, and our research findings, which came from the survey, and as well as other studies that were done by BC-CDC. And as a person who uses drugs and a peer research associate on this team with extensive experience in research relating to safer supply, I can personally attest that we were, in fact, able to give input at all stages of the study, both through our peer advisory meetings that occurred on a regular basis, as well as just offering input on data analysis, and doing actual surveys with people and helping with knowledge translation, such as this webinar here. So BC-CDC has definitely done a great job of ensuring that our concerns and priorities are at the center of the study. And I am going to pass that back to Jessica.
Yeah, so the aims of the study, the overarching aim of this project was to understand the needs and preferences of people who use illegal opioids and or stimulants who can benefit from accessing a safer supply and safer use services. So specifically, what that meant was we were interested in a couple research questions. So if people who use opioids and or stimulants were prescribed a continuous supply of pharmaceutical grade alternatives, which ones would they choose and why? What are people's experiences with concurrent substance use, and what substances do they use concurrently and why? And the why here being important because it was allowed us to have an understanding behind people's preferences. So understanding the substances they use currently, their reasoning behind it, and the reasoning behind their preferences for safer supply. We were also interested in how would people choose to use their preferred pharmaceutical alternatives, so the mode of consumption and why. And recognizing that roughly half of illegal opioids contain benzodiazepine-like substances. Sorry, my screen is blocked here. Are there concerns about benzodiazepine withdrawal upon a potential transition to safer supply and opioid agonist treatment? And a note, we also collected data on models. So asking people in terms of their preferences around staffing, settings for safer supply programs, prescriber practices, things like that. It's not necessarily the focus of this presentation and the report. We did share some data around models that's being used for model work by the PHO. So the focus here is really on people's preferences for substances and modes of use. So briefly about the methods. As Jane mentioned, this was a multi-method study. The quantitative component was comprised of 2 surveys, and that's the cross-sectional harm reduction client survey, which is a survey that's been done pretty much annually since 2012, I believe, and collects data at harm reduction supply distribution sites across BC with people who use illegal substances. And so in 2019, there were 22 sites that participated with 621 participants. And in 2021, 17 sites participated with 537 participants. And we draw on both these surveys. The questions, there are similar questions across the 2 surveys and annually, but there are also differences in questions because the CDC is constantly sort of adapting the questions to reflect different needs and the changing context. So for example, in 2019, we asked if you use down, what would you prefer to use? Whereas in 2021, that was replaced with or adapted with if you were prescribed a continuous supply of pharmaceutical grade opioids that is easy to access as an alternative to street opioids, which one would be your first choice? And then a descriptive and multivariate logistic regression analyses were done to understand preferences and associations. When it comes to the qualitative methods, we did a mix of interviews and focus groups. So we did 47 interviews and 6 focus groups with people who use illegal substances between November 2021 and February 2022. And these were facilitated, focus groups were co-facilitated by myself and a peer in their region. And interviews were facilitated, there was a mix, so facilitated by peers as well as myself. And they were audio recorded and transcribed. And then a thematic analysis was conducted using NVivo to identify patterns and relationships. And the peer advisory was involved in kind of looking at preliminary findings and deciding what themes were important to include, and also choosing the quotes included in the report and the infographic. So we'll get into the findings, and I'll pass it up to Jane to start us off.
Thanks very much, Jessica. So as I mentioned, we'll go through the sort of topic headings, and the first one is around opioid use. And I'll talk about the preference, what sort of opioids people prefer, how people use them, and why they use them in that particular way. So in our 2019 survey, which, as Jessica said, we asked which opioid do you prefer to use, we found that 58% preferred heroin, diacetyl morphine, and only 33% preferred fentanyl. The preference for heroin, it was higher in those who were older, and it differed between geographic regions. When we reworded the survey for 2021 and asked if you had an opioid safer supply that was easily available, what would you prefer? 47% said that they would prefer to receive heroin, and 23% preferred a safer supply of fentanyl powder. And again, there were differences between genders and geographic regions. The next slide, we asked people about their mode of use. And in the 2019 survey, we found that over 2/3 smoked their opioids. And then when we asked to get the similar question in 2021, we found it was almost 3/4, it was 73% smoked. In 2019, those who smoked were more likely to be younger and use methamphetamines. In 2021, the next survey, we found that people who preferred to smoke, to have the safer opioid supply, the numbers that would smoke would be 62% preferred to smoke it and 20% preferred to inject. And that was in contrast to the 73% who said they were currently smoking. So from that, you wonder if there was a safer supply of opioids, maybe people would not continue to smoke. The other question that we actually asked for in the survey in 2021 was around why people smoked. Thanks, Jessica. In 2019, I think it was really quite surprising. We hadn't realized how much smoking had increased in the use of opioids. In the past, injection had been the preference. But we found that not only in what people prefer to use, but also in the coroner's reports that more people were dying from smoking than other methods of use. But you can see here when people were giving a reason, almost half were smoking for safety reasons. Less likely to overdose, they thought, less likely to get bloodborne diseases like HIV, Hep C, or other infections like abscesses or endocarditis, and better able to control dosage. So really trying to be safer when using opioids. Just over a quarter preferred the effects from smoking and thought it was more social, able to smoke whilst using stimulants as well, and preferred smoking in general. And then again, just over a quarter didn't like to inject or had never injected, or perhaps their veins were difficult to find, could no longer inject. So I think it was really important to see that people were smoking because they thought it was a safer way of using, that people are trying to look after and be as safe and healthy as they can be. So now I'll hand it over to Jenny, who is going to supplement the numbers with the voices of people who use opioids.
Hi, everybody. I'm Jenny McDougall, and I was going to give a land acknowledgement, but I'm on Vancouver Island in Parksville, and I have no idea what land I'm on. So I will give a land acknowledgement of where I live. And I live, work, rest, and play on the unceded traditional ancestral territories of Lataco Dene in what's colonially known as Quesnel, BC. So the qualitative findings for the opioid safer supply preferences, many participants expressed a preference for a pharmaceutical grade supply of heroin and or fentanyl as they met the individual's needs and objectives. And here we have a quote from Oscar in Vancouver. They, in brackets, heroin, fentanyl, have the strongest analgesic effect and the strongest euphoric effect. I find that when I was prescribed Cadian morphine, it was helpful in terms of mitigating withdrawal symptoms, but it's more of a safety or stabilizing sort of function. So you're not getting that euphoric feeling. Participants shared that existing safer supply options were limited and did not reduce the reliance on the street supply. Here we have a quote from Thomas in Quesnel. Somebody using fentanyl, trying to replace that with Dilaudid or hydromorph, they're using their whole supply in one shot in the morning and they're screwed by noon. Another quote from FG4 participant. I'm on 4 Imezlon 100s and 14 Dilaudids. I use probably, if I'm being honest, 3 to 4 points a day of heroin, 2 or fentanyl on top of that. I don't get high from it. I just feel normal. And we'll go on to many participants were interested in a safer supply of heroin. Reasons given were a longer lasting high, fewer undesirable side effects compared to other opioids, behavioral and psychological effects, e.g. higher functioning, less sleepy, unique euphoric properties. And here's a quote from focus group 1 participant in Vancouver. I don't like dope with fentanyl. I don't want to get high to go to sleep. And here's another quote from group 3 participant in Vancouver. Heroin, you can do a little bit of heroin and get lots of energy. Yeah, you can work for a job. If you're just going to do fentanyl, then you're going to have to be willing to do what you have to do to get money every 10 minutes. And we hear that all the time. It doesn't have any legs. It does not last. I used to use heroin for over 20 years. And I can tell you, like, especially in the beginning, the first year or so, I could do a point for the whole day and I was good. Until my tolerance started going up, I started using more, but the effects were very different than compared to what I see and hear from people now. Some participants were interested in a safer supply of fentanyl. Reasons given: fentanyl perceived as providing better pain management compared to heroin. Concerns that heroin was not strong enough given people's increased tolerance from fentanyl use. Familiarity with fentanyl: some had never used pure heroin. And here's another quote from Nelson, focus group number 5 participant. Heroin is not the biggest pain medication where fentanyl is. You can use more heroin, where fentanyl, if you get a good, decent supply, you're out of bed just like that and whistling and doing dishes. And I kind of see that with some of the safer supply meds with people that aren't very dependent on the street supply still. So if they're able to get to a point where they can just use their meds in the morning, at least, I see that happening. I had somebody staying at my house and he took those meds, and when he woke up at about 6 and he looked over at me and he took his meds and he said, you know what's great? I don't have to just get up and run. I can go back to sleep and have a coffee and have a shower. And he did. And it was wonderful. Recommendations based on opiate and mode of use findings. So number 1 recommendation is include diacetylmorphine, heroin, in the Safer Supply Policy Directive. Implement and expand safer supply programs offering heroin across BC, not just in bigger cities. I just wanted to put that in there in my own words because I feel it's so important that we get the same access across BC with the amount of people dying. Number 2, safer supply programs should use various forms of fentanyl, including fentanyl powder. And from Jane's description, we do need that because there's no smoking options available right now. Number 4, sorry, the numbers just kind of screwed me up. Make injectable alternatives to oral forms of safer supply available. Number 4, make inhalable forms of heroin and fentanyl, as well as other safer supply options, e.g. stimulants, available.
Just a note on the numbering system, as Jane mentioned, we can count. These are just numbered as they appear in the recommendations. So there are recommendations between 2 and 5, which has mixed up the numbers, just so that you don't think that Jenny doesn't know how to count.
Or that our statistics are questionable because we can't count.
Because we can't do math. We can do math. Well, I can't, but there's other people on the team who can.
Yeah. I also have a note that I forgot to mention in the methods. The quotes, we've used pseudonyms, fake names, just instead of a participant ID to recognize that these are people and not just a participant ID, but it isn't their real names. So their confidentiality is maintained. And I'll pass it to Jane, I think.
Great, thanks everyone for supplementing and reducing the confusion there, hopefully. So that was the opioids. As we said, the preference for heroin came across quite strongly, and people wanted to be able to smoke and inject. Now we're turning to stimulants, and this figure is really from, shows the trend over time. So as Jessica mentioned, that we have done the survey at a number of sites across the province since 2012. And you can see here the kind of the blue color, not the turquoise, the darker blue. There's been an increase of crystal meth use. In 2012, it was 17%. And then in the last 2019 and 2022, both years, it was 72% reported using crystal meth. And you can see that the crack and the powder cocaine use has decreased over time. So we asked in the survey, in the 2021 survey, if somebody had prescribed stimulant, safer supply, easily available, what would you prefer? And we can see here that 59%, so the majority, said that they would prefer to have methamphetamine. It was just over a quarter and equally distributed between crack and powder, but about a quarter said that cocaine would be their preference. A much smaller percentage, 11%, said they'd have prescribed stimulants such as Dexedrine and Ritalin, and a very small proportion mentioned MDMA or ecstasy. The preferences for methamphetamine compared to preference for the other stimulants was associated with being younger. So folks who are less than 30 were 3 times more likely to prefer methamphetamine compared to the other stimulants than people who are over 50, identifying as a cis man, and frequent drug use. Those who use drugs on a daily basis were 15 times more likely than those who use just a few times a month to prefer methamphetamine. So now I will hand it over to Phoenix, who will provide the voices of people who use drugs.
So regarding stimulant preferences and using those to self-medicate, a lot of people reported that they did this to improve their daily functioning, to provide energy and productivity, and to manage physical, cognitive, and mental health related disabilities such as pain, ADHD, and mental health issues, such as myself, who uses cocaine daily to manage my ADHD and to actually get out of bed and do things. A focus group participant from Quesnel said that I know because of my illness, I lack energy a lot of times. So when I used to smoke the crystal meth or the crack, I would have the energy to do the things I couldn't do normally. As well, people who self-medicated were reporting that the prescribed stimulants are not comparable to stimulants from the illegal supply and don't provide the effects that they seek. I found Dexedrine kept me awake a lot longer, and it's really different than the meth. I would prefer the meth. I definitely don't like the way Dexedrine helps me because it's not even close to the same, said a participant from Cranbrook focus group. As well, many people said that they were using stimulants to address some of the effects of fentanyl and other opiates, such as extending the period of well-being, engaging in cost saving, using it to balance or level out. And there's some perception that the concurrent use of stimulants with opioids will reduce the risk of OD. A Cranbrook focus group participant said, it's like you got your upper and it keeps you up and you have that mellow feeling from the body pain, and it goes away when I mix it with the down. And some of the folks who preferred Dexedrine and Ritalin continued to use illegal stimulants, as well as access to the prescribed stimulants was restricted by prescribers. Many people were denied due to mental health issues. Quesnel focus group participant said that they were on Dexedrine and Ritalin my whole life. They won't put me back again, but I need it. Apparently I'm going schizophrenic because I smoked too much meth, but the prescriber said no to multiple clients. Different stimulants also have different effects, and people experience the same stimulant in different ways. Thus, they are sought based on the effects that the person needs. And a focus group participant from Vancouver said, when it comes to cocaine, I want cocaine right now. I don't want no prescribed alternative. Amen, brother. As well, current stimulant use may reflect availability and cost for some and not necessarily preference. For example, cocaine, when it's available, was preferred over meth if the quality was what it used to be and affordable. So there seems to be a bit of a switch to meth due to the rising cost of cocaine and the lowering quality of the street cocaine available. Next slide, please. As well, current prescribed stimulant alternatives are only available in oral form, so you can only take them as a pill. And as a result, people may be injecting these or continue to use from the illegal supply. Some participants smoked as they perceive smoking to be more social, associated with less stigma, and easier to set up and clean up. Nanaimo focus group participant said, I still smoke even though I don't get high, just as a social thing. You know, everyone else is smoking, so. And then Samuel from Victoria said that smoking is just a quicker, easier method. Other people transitioned to smoking as they developed issues with other modes of use, such as poor vein health for people who inject or damaged nasal septum for people who snort. Another Nanaimo focus group participant said that they ended up having to start smoking because they just fucked up their nose so badly that they literally couldn't snort anymore. So these are the recommendations that we are asking based on stimulant and mode of use findings. So we ask that you provide a regulated supply of stimulants that people are accessing from the current supply, such as methamphetamine, cocaine in both forms, and desoxin, in addition to currently available prescribed alternatives such as Dexedrine and Ritalin. As well, make injectable alternatives to oral forms of safer supply and inhalable forms of heroin and fentanyl and stimulants available. And I'm going to pass it back to Jane.
Thanks, Phoenix. And of course, I think everybody's aware of the issues around benzodiazepines. So I just wanted to give some background here and what we've noticed. And this is BC based, but I'm sure it's very similar elsewhere. So the prevalence of benzo-like substances in the illicit opioid supply really emerged in 2020. And this was brought to our attention by people who used opioids as well as overdose prevention service staff. There was prolonged sedation. And then when we looked at various data sources, it was corroborated. So biological samples we found from the coroners and also from life labs that there was an increase of benzodiazepines, and it started off mainly it was atizolame, but it has changed over time. We also found from drug enforcement samples, so these are ones that are checked by Health Canada routinely when a sample is confiscated and the person is being charged, and also through the community drug checking. I just wanted to highlight here that the drug checking, there are some concerns around the benzo test strips because they have limited sensitivity. Benzos and atizolame are not very water soluble, and the recommendation is to vigorously shake, and that may help do some solubility. But if you have a negative result, it can't rule out the presence because of this, because the sensitivity of the drug testing strips aren't very good. We obviously had this major concern that if people were transitioned from the illicit supply of opioids onto opioid agonist therapy or prescribed safer supply, that if they weren't getting the benzodiazepines, then they would go into withdrawal. So we developed various information sheets around benzo withdrawal, what it was, how to respond to an overdose when benzos and atizolame were also present. Obviously, opioids overdose responds to naloxone, but the benzo-like substances have this long period of sedation afterwards. So now I'm handing it over to Jenny to hear the voices of people who use drugs and what the benzos in the supply has meant to them. and safer supply regarding benzos.
Thank you, Jane. So interviews and focus group participants raised concerns about illegal opioids being contaminated with the benzodiazepines. Benzodiazepines are major adulterants contaminating the opiate supply. And Ariel from Kelowna says, so I would say that I also have a benzo addiction because it's really hard to get stuff down on the streets that does not have benzos in it. 2 is severe risks associated with benzodiazepine withdrawal. Once someone is dependent, there's also the danger of them quitting cold turkey, because quitting the benzos cold turkey can cause seizures, as from Taylor and Maple Ridge. On the qualitative findings, benzo-like substances contaminating opioids. Number 3, increased risk of overdose and sedative effects of benzodiazepines. Loss of memory and consciousness and being victimized, e.g. theft, physical or sexual violence. And we do hear of that quite often. You have these little glimpses of the memory of what happened, and then you're on a mat in a holding cell. It's like, oh, that's not something that I think anybody intends to do when they're picking up any substance, right? And that's from Evan in Kelowna. Gabriel and Victoria, if you do the benzos, you're out, and people can do anything with you when you're out on benzos. 4, many people now have a benzodiazepine dependency that forces them to seek out and use more illicit opiates to try and find opioids containing sufficient benzodiazepines, despite safer supply and or out. A lot of people are wired to the benzos. If they get fentanyl without benzos in it, they're still sick. And that's a focus group participant in Vancouver. So the recommendations based on findings about benzo-like substances, we have safer supply programs need to include benzodiazepines, and prescribers should consider providing a safer supply of benzodiazepines to those at risk of benzodiazepine withdrawal or health concerns that can be addressed with benzodiazepines. And with the work that I do a lot of medication delivery, taking people to doctors for safer supply and OAT. And that is one of the biggest issues that I see, even for people who are wanting to go on to treatment and stuff. The benzo withdrawal and the way they're treated when they try to go in the hospital to be monitored, going through those withdrawals, they're kicked out. They're drug seeking is what they're told. They don't keep them in, even though they're told that they need to be monitored to go through that withdrawal. So yeah, it's very, very unsafe.
Thanks so much. And I really appreciate the context that Jenny and Phoenix are able to add to the findings that we're sharing here. So this is the final numeric data that I'm going to share. We hear concerns about people diverting prescribed safer supply or the risk mitigation guidance, but how many people are actually having access to it? And from the survey, we found that less than 1 in 6 people had received any prescribed safer supply. So that was the 16.5%. And what we found was that among those who received the safer supply prescription, just over 2/3 had received opioids, 1/3 had received a stimulant, and only 10% received a benzo. So I think that really does show how, even though people have been on opioids and them being prescribed the safer supply, they are not getting the benzos in addition to the opioids. Compared to people who didn't get a prescription for safer supply, the person who does get a prescription is more likely to both smoke and inject drugs in the last 6 months, more likely to use substances every day, be younger, and be engaged in harm reduction services. So it's not surprising that somebody who perhaps is using overdose prevention sites or has been on opioid agonist treatment or drug checking services is more likely to have access to somebody to prescribe the safer supply. So now I'm handing it back to Phoenix to give some quotes and some voices in that respect.
So beyond just the need to expand the substances and modes of use available to make safer supply accessible, a lot of participants discussed the barriers that they experienced that were related to the gatekeeping of safe supply via healthcare settings, such as prescriber willingness or unwillingness, prescriber practices, such as the rules for pickup and urine drug screens and that sort of thing, people being kicked off of their safe supply or OAT if they miss pickups, things like that, as well as just the overwhelming experience of stigma that is present in healthcare settings, and the lack of adequate substances in adequate doses. So taking this into consideration, when we're considering models and requirements for pickup, we need to make sure that they are appropriate for rural and remote communities. So a participant from a focus group in Nanaimo said that, yeah, it also depends literally where you're at in BC. You could go to a different city and be given like anything as opposed to what we have available here. And it doesn't make any sense whatsoever. And a Quesnel focus group participant said that, I know it can be problematic when it's not reaching people that are not able to get into town to get it. I'd like to see something that would be accessible. This also, oh, my apologies. This also included barriers related to policies around missed doses, as I mentioned, that were inflexible and led to people being cut off from their safer supply and OAT, as well as undesirable program settings and requirements. A Nelson focus group participant said, but for me, like using the safe supply would be having that safe supply there all the time. But it's not there all the time because doctors shut you down after 2 days. Why am I even on safe supply? It feels like these programs don't understand why people are trying to get on safe supply, because being junkies and drug users, our lives are fucking chaotic. So sorry, sometimes we can't get to the pharmacy for a couple of days because, you know, who knows what chaotic instance is happening. But this is why we need safe supply, so that we are not involved in that chaotic street and drug use community and environment anymore. Another participant from a focus group in Vancouver said, I could quite happily get heroin and get carries and you wouldn't see me. I'd pick up my carries, I'd be out working, doing whatever I wanted to do to get out of here. Like right now I take morphine, dillies, and diacetylmorphine and fentanyl simply because I don't want to go to the fucking clinic 3 times a day anymore. So here is our recommendations based on the findings related to access programs and models. We are asking that providing low barrier models that include virtual and mobile options, take home dose options, and flexible and appropriate policies around missed doses to ensure access to safer supply programs. We are also seeking a Section 56 exemption from the federal government to legally develop, implement, and evaluate non-prescriber-based safer supply models, such as the Dolph Compassion Club, which I am a member of, and it has absolutely changed the way that I buy and use drugs. Provincial governments have a role in supporting the implementation of non-prescriber safe supply models, such as compassion clubs and co-ops. And number one for me is including people with lived and living experience of substance use from top to bottom in the design, implementation, operation of safer supply programs, in leadership roles, not just in tokenistic roles, to ensure that these programs are aligned with the people's preferences and needs and increase access. So
Thank
here,
you.
oh, sorry, was that?
I think I'll take this one, and then we'll open it up for everyone to give their thoughts. But thanks so much, Phoenix. I think what you mentioned there is so important, and that brings us to the policy and practice implications. So, you know, safer supply aims to provide an alternative to the illegal market, and embedded in that is a requirement that safe supply be acceptable and accessible. to truly provide that alternative. And I think what we're seeing with our findings is that there's a misalignment between people's preferences and what's available, and we really need to be expanding the options in order to make it accessible and truly meet that aim of safer supply. And as Phoenix said, there seems to be that misalignment, and the expansion is needed urgently. There's not really any time to wait for that expansion. Our findings were mostly around sort of the substances and modes of use preferences, but there needs to be movement on all fronts, including making low barrier models accessible, and expanding options in terms of the actual substances and modes of use. And these findings are relevant to all models. So whether it's prescriber-based models or non-prescriber models, it's important that there be a range of options when it comes to the substances and the modes of use. So specifically, and I'll add with these are some recommendations, and I'll add with the caveat that we need these urgently, like I mentioned. So we need to be expanding the substances offered, as we've talked about, and aligning them with the preferences and needs. So we heard about, for example, the preference for heroin and fentanyl, and yet these being some of the most difficult to access across the province. The need to include inhalable formulations, recognizing that one size does not fit all. Obviously, people who use drugs is a very heterogeneous group, and we don't mean to suggest with these preferences that if there were these few available, that would be acceptable. We need a range of options because there are a range of needs, diverse needs. We need to be challenging access, so exploring low barrier prescriber models. And as Phoenix emphasized, engaging people who use substances to ensure diverse needs are identified and met, and also identify shifts. So this is kind of a snapshot of preferences and needs, a snapshot in time, but they're likely to be changing as different forms of safer supply become available. So for example, if many are primarily smoking for safety reasons, we may see a shift in terms of modes of use if people had access to the opioid of their choice or the stimulant of their choice. If stimulants are used by many to balance the effects of fentanyl, if people have access, again, to a safe supply of the substances they need, we may see a shift in polysubstance use. And the kind of our data around the patterns and people's reasoning for using certain substances really helps understand or anticipate some of those shifts, and understand people's preferences. So with that, I will open it up. Jenny, Phoenix, Jane, if you want to add anything about the findings, or just the current context of safe supply.
I would like to jump in just with a quick couple of thoughts, and then I'll hand it over. So I wanted to just say in Quesnel, for the last just about 3 years now, I've been doing the delivery of safe supply and OAT. I work very closely with our prescriber, and the change that has happened since I started doing deliveries to people who are unhoused, to people in the shelter, to people in supportive housing, to people in the hotels, or homes has been remarkable, not only to maintain on their medications, but also other health care issues that they might have, and also housing needs, and also visiting their children or family members, doing jobs, like people are now working with Clean Team or in our OPS sites. It's really built relationship up between, like I'm a bridge between the person coming in and the prescriber, as well as ER rooms, urgent primary care, all MCFD, like all of these different things. When we have peers working in that area, we can also do like help with communications, where the doctor might not be understanding what the person's trying to say, or vice versa. It's just been a remarkable change, and the overall outcomes are so much better for the person that's either on these medications or ends up on another path But that's how I met them, was doing, supporting them for OAT and safer supply meds. So I feel like the delivery model, which must be peer, it has to be a person with lived experience doing this, or it won't work the way it works for me, which has been very, very successful. The people open their doors to me, even when they're even when they're messed up. They wouldn't do that if it was just, somebody that that you don't feel comfortable with, somebody that's not like them, and I feel like it's vital that it's peers doing this model. It's been so successful that we have people a person doing their thesis on this program. There's people calling from all over BC wanting to do research on it. Like, it's just been amazing. And if we had actual access to the medications or prescribed models or non-prescribed to go with that, it would be remarkable. And I just want to say one more point. We need RN prescribing. We need the psych nurse prescribings. We need them to be able to prescribe not just full spectrum OAT, but also safe supply medications. It doesn't matter how many meds we're allowed to have. If we don't have prescribers to do it, what's the point? We had some doctors jump in and say they're wanting to do this, but recently, over the last couple of months especially, there's been a major shift, and all over BC, people are just being randomly cut off and the excuse used from many of them is, oh, that was just for COVID. It's not just for COVID. It's general practice now. And that's been updated. So I don't know if some prescribers aren't aware, which I don't believe that. I mean, if they know all the rules to cut people off, then they probably know the rules to help them stay on as well. And what their practice guidelines are and clinical guidelines. So we are aware of all of these, the peers that do this work. We're aware of what our rights are and what clients' rights are and what prescribers, what they're supposed to be doing. So I really feel it's very important that we get the education for RNs to be able to start prescribing safe supply as well as full spectrum OAT. It has to be done. It has to be done. Thank you.
Thanks so much, Jenny. I think there's so much important that you just mentioned, and it's so valuable to have Phoenix and Jenny here presenting. They bring so much to this work. And Phoenix, I don't know if you wanted to add anything.
Sure. Yeah. I mean, like I've been saying in the Q&A, like a lot of the questions that you have for us, unfortunately, like we can't answer them. Like, how do we increase access for safe supply? I don't know. I mean, the community is always taking it upon themselves to serve the community. And that's what's happened with DOLF and with KISS. I mean, there's a lot of risk and a lot of danger and of criminalization involved. But I mean, if the government isn't going to change things, change the legislation and make these things available to us, and I don't mean prescribed alternatives, I don't mean pharmaceutical alternatives, I mean the actual drugs that people are taking need to be provided. So just like a brief primer on co-op and Compassion Club models. I am working with DOLF. I'm a member of the DOLF Compassion Club and a member of the advisory committee. And so what they do is they buy substances in bulk from the dark web. They take them to get them tested. They provide packaging with the ingredients, a code number to see the results of the test, and a vacuum sealed package that is weighed. It's the right weight. It's not, there's no like shaving off the top of the bag. There's nothing like that. And yeah, there we go. The evaluative framework was just put into the chat too. And so I go there. I know that they're going to be open at a certain time. I know that I don't have to try and stand out in the rain and call people for an hour. I don't know that I'm going to be, sexually assaulted in exchange for trying to get drugs. I'm just going to go to a storefront, buy my drugs for a reasonable price, do them there, and know that I'll be safe. And this is what we need for every drug that people want to do. Unfortunately, they're not able to offer fentanyl at this time, which is a real problem. But they sell heroin, methamphetamine, and cocaine that are pure, tested, known consistency, and of a same price. It's all very reliable, which is my issue with buying drugs. I can call a drug dealer 5 times, 10 times, 20 times. They're not going to answer if they're not available. I know that it's between a certain set of hours on a certain day. I know DOLF is open. And just with the extensive experience that I have on research with many projects on safe supply, the one size does not fit all is the thing that I've heard in every single project. Every finding is all related back to that. Drug users are not a monolith. We're different people with different needs and different reasons for using, and we all need different safe supply models to serve us. Some people are going to want to just, like me, go to a store, buy their drugs, go home, or use it there, and they don't need wraparound services. Other people have mentioned something like a community center where they go to a house that's owned by a drug dealer or a drug user organization, not a drug dealer, sorry, owned by a drug user organization. They go there, it's a community center, they maybe have showers, they've got food, they've got clothes, you can meet with a social worker or a counselor, you can get legal help, just a one-stop shop for all of the services that people need. And this is a class issue. This is drug users in different classes have different needs, as well as drug users in different cultural communities have different needs. So we really need to be just making sure that when we're developing these programs, that it's all coming from the bottom up. Thank you.
Thanks so much, Phoenix. I'm seeing a lot of clapping hands and hearts, so I think there's a lot of agreement there. So that brings us to the end of our presentation. Here are the recommendations the 13 recommendations in order that are included in our report and our infographic. And we kind of went throughout. And I think the report and infographic will be shared, as well as our, we have our emails there. So please reach out if you have any questions or just comments. We'd love to hear them. Yeah, and we'll open it up for Q&A, I think.
I also just have one more thing to say. That is one of the participants who shared a lot with us. They passed away during the course of the study, and it just shows that we're still losing people. People are still dying.
And I think there was a question.
Can I just add to that as well? And I just read that, I forget the person's name, but he had that store in Vancouver where selling actual drugs. They shut him down and he died like a few days later. So I'm guessing that they took his supply as well with the arrest. As soon as they shut down that safer option, he dies.
I think he was sober though. I think that was a relapse.
Oh, yeah. Okay.
Yeah.
But still, right?
The stress of being shut down and all the publicity and being arrested probably led to that. Yeah.
Yeah.
Well, thank you for that presentation.
I think Jane had a question that she wanted to answer.
Jane, go, Jane, go.
So I just put it in the chat. You shared the link for DOLF, but I just explained that it was the Drug User Liberation Front was what the initials meant.
We'll take a pause in this moment. We have a Zoom poll that we want folks to answer, and hopefully, if you don't mind doing a little feedback survey for us, I'll launch the poll right now, just to get it going. I'll leave it open for 5 minutes, whatever people need to fill it out. My colleague Robin is going to pop in the survey link. Thank you for the presentation. It was really fantastic to hear all of that information from 4 different voices and 4 different experiences and perspectives. There's been a ton of action in the chat. Not sure if anybody's noticed. So the chat, but also the Q&A. And so there's been over 13 questions that were asked. that have been answered, which is kind of cool. But I also wanted to take the opportunity to maybe go through a few of them with my colleague Robin, and we can like see if you folks have things to add. I'm going to go through really quickly a few of the ones that were like really easy answers. Okay, if that's okay. So the first was somebody wanted to know more about co-op models. What resources do they include? I plugged them, the Drug User Liberation Front website, as well as the KISS site, which is the Kootenai Insurrection for Safe Supply. That's what that stands for. I also popped in a resource from the BCCSU on heroin compassion clubs. It's a bit dated though, because it's from 2019. Other things, somebody was asking very specifically about where you can find safer supply programs in your communities. Very unfortunately said, and quite like straight up said, there aren't safer supply programs in all communities, which is really kind of the sticking point and the hard point right now.
And I mean, even if there are, there's no one resource to find them all, which is like,
exactly.
With one of my other projects, we've been trying to set up a zine, and we're like, we can't offer you information on how to find it because it's not static, it's ever changing. And
yes. So there's a working group of people who use drugs at the community of practice who took on creating this national resource list of all the safer supply programs, and even on our list it doesn't have them all, and changes happen, right? Like it's this, like you said, it's always changing. So the best thing I can do for people that are like asking those really specific questions is pull up in the resource that Robin just popped in. Other things that I think were just like easy things to answer, I just want to make sure that like if there were other things that, you know, like Jessica or Jane or Phoenix, if you had more to say about the differences between risk mitigation guidance versus safer supply. I think, what other ones? I just want to make sure that like the things that were addressed, like got that chance to be talked about, and then we could like actually talk about the questions that are waiting for us.
For sure, yeah. I mean, regarding the RMG versus OAT safe supply thing, I mean, the risk mitigation guidance prescribing in BC included stimulants and other drugs, so it technically is an OAT, which is opioid agonist treatment, but it's still a treatment focused prescribed alternative versus an actual, like, you know, enjoyment, pleasure seeking thing for people to continue to use safely. And the drugs available are not the drugs that people want to use. So that's just a bit of my personal bugbear about not thinking of RMG or OAT as safe supply.
Yeah, and just, I mean, RMG was very limited. And as Jenny pointed out, it's folks are being cut off because, you know, COVID is no longer seen as an issue and it was introduced for that purpose. There has been some evaluation within BC, and colleagues at BCCDC, Amanda Slormwhite and Heather Palis, have actually looked at deaths where there has been dilaudid and hydromorphone detected and there has not been an increase. There have been concerns around youth, and that's not something we have seen, that there's more youth are being more affected than other age groups. So, you know, obviously we have to constantly look and make sure that we are doing no harm. But I think, as we all know, that giving somebody dilaudid tablets can help reduce withdrawal symptoms, help folks to be able to function until they can get what they need to be able to be well. But it's not the answer. It's not enough.
Yeah, and maybe just to add one final thought to that, I think safer supply being sort of this alternative, that's going to look really different from person to person, depending on what they're seeking an alternative for and what they're aiming to do. I think with our findings, we found that some people were really just looking to take care of withdrawal symptoms. Some people were like wanting the euphoric properties. So all of that kind of plays into what's considered safe supply.
So there are, I'm sorry, I'm trying to go through the rest of the questions, and I think we can maybe go over to the open ones. Robin, did you want to maybe pick one to go with?
Yeah, I think that actually ties in, what people were just saying ties into the very first question that's in the list, which is, if many participants find currently available oral formulations of safer supply ineffective, should physicians continue to prescribe them, knowing that regulated fentanyl, diacetylmorphine, and inhalable safer supply are not widely available? That's a big question, but I'm sure people here have thoughts on that.
I can start us off. I think it's on all of the above. Like we were saying, there is no one size fits all. Yes, though these options aren't working for many, but they are working for some. And you know, even some people are using them in addition to substances from the street supply. Many are. And while that's imperfect and there's still a risk of overdose from accessing the street supply, if that means fewer times accessing the street supply, that is still reducing risk.
Anybody else want to take that one on?
I think Jessica said it well.
I do too. There's another question that's come in the proposed model for safer supply, where someone could access a storefront type model like a liquor store. Who would manufacture the sanctioned supply? Like, for example, pharmaceutical companies, and how would the supply be funded? Provincial drug plans, direct payment, other options.
So I'll take that one. It depends. There's different ways for those models to be done. In a community regulated model, it could be bought from a trusted supplier, bought from the dark web, and paid for in cash at a wholesale rate, which is what DOLF does. In terms of like a government run sanctioned, it would have to be coming from pharmaceutical or other manufacturers, but that's going to need massive legislative change that we don't really have control over at this point. But I don't think that in that model it would be required for coverage unless you have a, you know, like there could be a mechanism for that, but I think most people in that situation would be paying cash, would be paying money for it, because that would be, and I hate to use the term higher functioning, but that would probably be a model that would be most appealing to folks who are higher functioning, who maybe have more disposable income versus people who would need to have their medications or drugs covered.
Anybody else can answer or like want to venture there? Because I actually find this question incredibly interesting. We follow the news quite a bit and have been actually following a company that is called Safe Supply Streaming. And it is sort of like the potential, how can I say this, like capitalist venture for safe supply provision. So I will show the link in the chat because I think it's one of the ways that this could happen and one of the ways that, like, I think, in my personal opinion, I would prefer it didn't happen this way. But I think it's a way that it could happen. And yeah, I think this like storefront model, the sanctioned supply, it depends, right? Like depending on who is operating this storefront model, like whether it's a drug user organization or like whether it's a sanctioned space by the government, like that will depend on who the provider of the supply is, right? So for the Drug User Liberation Front, for example, like their source is from the dark web. They're very open about that. They don't hide that. They don't disclose the source. And then they're very, you know, like clearly testing it and labeling it. That's the way that they source that. But for sort of like safer supply programs that are like operating, say, in Ontario and BC, like those are through like funded, like, you know, pharmaceutical companies, right? And some are like some provincial drug plans or territorial plans cover certain ones, others don't. Often plans won't cover the dispensing fee, that kind of thing, right? So those are all things to consider too. Spelling it, saying now storefront link or spelling. Sure, yeah. Sure, anonymous attendee, I will share that information in the chat, no problem. Yeah, does anybody have anything else to say about that? Yeah, I think it's a really interesting conversation. Anything else?
Yeah, maybe I'll just add that I think there's so much in that question. And to an extent, those conversations need to be had, but have been blocked by just this lack of political willingness to even go there in those conversations. So yeah, I think there's, like you said, it's going to look different depending on the model. But it's felt like at some points we haven't even been able to get to those conversations because we're just sort of fighting to have it acknowledged that we need this.
So another question that was in the answered ones that might be interesting to revisit verbally. Do you think there's some nostalgia bias present in people's preferences? In other words, if access to heroin increases in the market, would people whose tolerance has increased due to prolonged exposure to fentanyl and these other medications no longer work for them, would they go back to heroin? And Phoenix, you had typed in an answer to that, but do you want to respond verbally?
I mean, I was really excited when I first heard about the Dolph heroin program. I was like, yeah, I'm going to cut down my fentanyl use and I'm going to transition from fentanyl to heroin. But I actually found that the heroin that's available, it gives me itchy. It makes me feel itchy and gives me pins and needles, which is a symptom that I had previously, but I suppose I'd forgotten. So it's really just about what you prefer to, what your preferred sensations are. If a lot of people are actively enjoying the heroin program, they've cut down their fentanyl to meet tolerances, cut down their fentanyl use and upped the heroin to make a bridge, and that's worked for them. But it's really about personal preference. We just need to make sure that we have everything available so that people can choose what works best for them.
Yes, I think it's really important that, yes, the majority of people said they would like to have heroin. Yes, it was the older folks who that may be some nostalgia there as well. But we just need to have the diversity of options available so that people can have what they need. And it may be that, yes, people's tolerance has increased with fentanyl, but that doesn't mean that it cannot be adapted. I mean, a lot of people have opioids and are tapered successfully. I think it just means that there needs to be, it may not be as easy somebody doing it themselves. They may need some assistance in to make sure that they are reducing and getting onto the heroin and using heroin. But we've got so much evidence from the Naomi studies and the Salome study that, you know, heroin, diacetylmorphine does provide what people need for many folks that have been on it and who have been on it for a long time.
The thing with fentanyl versus heroin is that, like, fentanyl you need to use a lot more. It's cheaper in terms of the provider, like it's cheaper in terms of the person selling it because it's smaller and it's more potent, but the street price hasn't changed. So you're still getting, you're getting the same weight, but it's also 95% filler. So you're getting the same weight, but you're paying the same price, but you're not getting a larger amount of the drug, and it works for a shorter time. So you need to do more and more. So it's increasing in expense while also increasing in adulteration and things like that. Exactly. Yeah, Jared, that's exactly it. So it would probably be worthwhile for a lot of people to transition back to heroin or transition to it if they've never had it before.
Yeah, as we heard that people could have a job when they were using heroin, which they find very difficult with fentanyl because they need to actually get it so frequently.
I'm just noticing the time. And then also remember that we're in a webinar, not a meeting. Sometimes that happens when I'm in webinar mode. But yeah, it's been nice hearing from you all. There's one more question that somebody popped in the chat. I'm going to read it. I'm going to give all of you the last words, and then we'll close out. One challenge we keep hearing from the programs that provide fentanyl in their safer supply program is that it is too expensive and cannot be sustainable if the cost is transferred to the programs and not the healthcare system. On the other hand, the client pay model in BC seems to have 30 people on board. Any thoughts on those two?
Yeah, so the thing about the client pay model, I'm assuming you're talking about the fentanyl program that Dr. Christy Sutherland is running. She is charging $25 a quarter gram. Street price for quarters are $20. So nobody's going to go there to, even if it's better fentanyl, even if it's, you know, like it's not feasible financially. It needs to be slightly less than the street price in order to make it appealing. Otherwise, it's not going to work. And the reason that they did that is because they don't want people buying it and reselling it, which is a feature, not a bug. People are accessing the Dolph Compassion program, buying it, sharing it with their friends, getting more people interested, getting, you know, and I understand that that might not be what that program wants to accomplish, but if we're talking about a model where the person is paying for their own substances, it needs to be as cheap and as easy as calling your guy. That's it, or it won't work.
Fire. Any last words, responses? We lost Jenny there, but hopefully we can connect with them afterwards. I do see like claps, I see hearts, I see thank yous, great presentation, great discussion. Any last words, Phoenix, Jessica, Jane?
Thank you for having us, and also thank you, like Jane mentioned at the start, for everyone's work on safe supply and everyone doing so much work around this.
Thanks, y'all.
Cheers.
Thank you.
Thanks a lot.
Yeah.
Ciao.
Okay. All right. Thanks, everybody. So we'll have the recording up tomorrow, and we'll circulate it in our newsletter and on our website and all sorts of places. So stay tuned for that. And like I said, thank you so much, Jessica. Thank you so much, Jane. And hope to see you again soon. Bye.
Great. Thanks. Bye, everyone.